This clip presents the cases of a woman who was given the diagnosis of gestational hypertension and preeclampsia during her first 2 pregnancies, before the correct diagnosis of atypical hemolytic uremic syndrome was recognized at her 3rd pregnancy. The core features of preeclampsia are proteinuria and hypertension. Some patients may also have the HELLP syndrome, renal failure, and complications of abnormal vascular permeability. Such variations suggest that preeclampsia may not be a single disease. Atypical HUS has been defined by the triad of renal failure, microangiopathic hemolytic anemia, and thrombocytopenia. Other features of atypical HUS include hypertension and systemic complications due to abnormal vascular permeability. These features indicate that atypical HUS can be quite similar to preeclampsia in clinical manifestations. Atypical HUS has been associated with molecular defects that affect the regulation of the alternative complement pathway. Such mutations are also found in about 10% of the cases in clinical series of preeclampsia. This indicates that some patients given the diagnosis of preeclampsia have atypical HUS instead. Some patients with atypical HUS mutations may present as hypertension with no renal failure, hemolysis, or thrombocytopenia. Therefore, atypical HUS may also be mistaken to be gestational hypertension during pregnancy. The patient of this report was given the diagnosis of gestational hypertension during her first pregnancy at the age of 18. Her second pregnancy at the age of 20 was complicated with hypertension at week 35, and after delivery she had other complications which were initially attributed to postpartum preeclampsia. She was eventually treated as TTP/HUS with plasma exchange, supplemented with high-dose corticosteroids and rituximab. With these treatments, the course was protracted and lasted for 5 weeks. After that, she continued to have hypertension. When the patient had her 3rd pregnancy at the age of 22, it was complicated with, quote, preeclampsia, unquote, at week 22. After emergent delivery, her conditions continued to deteriorate. When kidney biopsy showed the pathology of thrombotic microangiopathy, the patient was started on anti-complement therapy with eculizumab. Her platelet count normalized in 3 days. Her extrarenal symptoms also improved in 1 week. In contrast, the recovery of renal function was much slower. It took 3 months. Molecular studies detected a mutation of complement factor H. This confirmed the diagnosis of atypical HUS. Key lessons from this patient are: first, atypical HUS can mimic gestational hypertension, preeclampsia, and HELLP syndrome. Second, although atypical HUS is a serious disease, anti-complement therapy is very effective for its treatment. And third, atypical HUS should be suspected when renal failure is prominent or overall conditions do not improve after delivery.